right? I can put my hand here. If I want to do more shoulder extension, this hand could be here. If I want to do more elbow, then I'm going to resist, extend. I can resist, yep, push, push, push. I can resist her elbow extension, okay? And I can do fingers too, okay? If I want, in the hand, you can, depending on where you put your hand, this will just give me wrist, right? So if I'm here, that'll just give me wrist, okay? If I actually put my hands across there, now when she's pushing, I'm doing more finger extension. So you really can get what you want based on where your hand is placed and where you give the resistance. So what I would do for a beginning CVA patient is I would say push out, and I'm giving resistance into that diagonal. Relax, and I bring the patient back. Just concentric into the direction of the motion. And I would just keep working that, okay? The D2. The D1, they have no problem doing that. The D2 flexion. They really don't have a problem. So if I start here and I say, make a fist and come into this direction, if they really don't have a problem coming in. And then if you want, you could do rapidly alternating. Down, so we're going to do the flexion. I'm going to give her slight resistance, and then we're going to do the extension. Okay? And we're going to do the flexion. Great, and I'm alternating that with extension. So now she's doing rapidly alternating, or hold the shoulder in, and don't, when she does the D1, push out, don't do so much of the what?
Sublux.
Don't do so much of the shoulder, because that hurts the patient. So you can still do it, just reduce the shoulder so it doesn't hurt. Okay? I would say that if the patient has a tight scapula, right? So their scapula is hypomobile, then I would do scapula first, loosen it up, and then I would do upper limb. Okay? If the scapula is hypermobile, then usually what I do is I would do the diagonals first, and then I would have her go sideline, and then work on the scapula. Why that is, I don't know, it just feels right to do. So, because if it's hypermobile, if it's moving all over the place, well, you could look at it two ways. You could try it. If it's hypermobile and you do the scapular patterns, you want to ask yourself, did that make the scapula tighter and not all over the place? Is it better? If that's the case, then maybe do that first and then do the upper limb. So I think with that, you have to kind of see, did you fatigue them and now their hypermobility is worse because now they don't have any tone at all because you just worked the crap out of their shoulder, right? So if that's the case, then I won't do it first. Does that make sense? So I don't have a really, I guess for me it's a feel issue and what I think is working the best for that patient. That's the best advice I can give you. You got to try and see what happens. Because if they're hypermobile and you do the PNF and it feels better, then I would do the scapula first. But if they're hypermobile and you just fatigue them even more and now it's even more tired, then I would not do that first. Because you are working a bit of the scapula when you're doing the diagonal pattern. You're moving the shoulder. You are using the shoulder girdle. Okay? You're trying to kick in those muscles as well. So that's the best advice I can give you. Does that make sense? Okay, so so I showed you the D1, right? Yes. Switch your hand placements, right? In, pull in, make a fist and pull in. Okay. So that's the D1. The D2 is going to start right. If you go in this direction, they're going to pull in this way. I'm going to change. She's going to make the fist and she's going to push out. Okay. Yep, in, and towards your hip. Good. So that's your hand placement. Okay? So you practice the hand placement. Now let's go sideline. In the direction, so if you don't mind here, I'm going to come this way. Unstable or the patient. Don't say it! Don't say it, don't say it. We don't want to reinforce abnormal movement. So on Nichelle, what was happening with her, I'm working on it. It's my goal for the end of the semester. So on her, we saw last time she would come up and she would go right towards her ear. So you can't reinforce that she had extremely tight upper trap, weakness lower trap. You don't want to reinforce that abnormal pattern there. So you want to make sure that the patient is going in that direction. And that when you do the PNF on the scapula, that you're actually working that direction. Does that make sense? And so you're going to start with the basics again. Is you're going to just relax. You're going to start with passive motion. And I'm just feeling for range of motion. Okay, I'm just feeling how does her scapula feel? Does it go all the way? Is it tight in any direction? That's what I'm feeling for. Or is it very loose? Too loose, maybe. I don't know. We'll see. You compare the other side. I do that a lot. So, and then once the patient, you move through the diagonal, you get to feel what passive feels like. Then you're going to have the patient move with me, Diane. You're going to have the patient move with you. Okay, and she's a little difficulty doing this, so try to go in this direction for me. All the way up, and then come down this way. Good, we're going to go in that direction. Okay, so you have a little trouble? Good. I find patients get pain relief with this. So how's that possible? A patient has pain in the hand or elbow, and they get pain relief with this. How's that possible? Could be radiating pain. Remember, all your brachial plexus, all the nerves coming out of the neck, go underneath the clavicle over the first rib. So by me doing range of motion of the scapular girdle, I'm actually moving the clavicle away from the first rib. Okay? And that can, make the shoulder feel better, free up the nerves, take the tension from the neck going down to the hand. So I saw on the vet, right? Pec minor. When you take pec minor off, the brachial plexus is right there. So if pec minor is real tight, then perhaps it's crowding the neurovascular limb. So it can be caught underneath the clavicle, it can be caught underneath pec minor. So patients, whether they're stroke or not, can have pain relief just from doing the scapular panel. That's good in my opinion. Okay? So after you do what? Right, rhythmic initiation. And then it depends on the direction. If I feel that she doesn't have good upward rotation, then I might work on them. Okay? If I feel that she's very tight here, maybe I want to work on the opposite of that. So maybe I'm going to work her in this direction. So if this was Nichelle, what I would do is... Anyway. What I would do... If this was Nichelle, I wouldn't want to work what? Upper traps, right? I wouldn't want to work that direction there because she's tight that way. So I'd have her push in. So I'm working this way, relax, and I'm going to bring her back. Push in, relax, and I'm going to bring her back. Okay, so that's what I would do. All right? So that's one diagonal. The second diagonal is this direction here. And again, you can cup this way. The other thing I showed you too last time, just as review, and then I'll let you practice and I'll shut up, is what we had to do is that when you give resistance here on the superior acromion, go ahead, yep, push up for me. And so if you see the patient's deviating, then what we had to do is give a little what?
Cue.
A cue, more the posterior, and that will bring her back correctively this way and get more of the middle rhomboid kicking in instead of just upper trap. You get middle rhomboids and middle trap kicking in a little more. The other direction? Yes, this way. Thank you. We're going to go this way, right? Up and forward, down and back, this direction. Again, I do passive first. You can check right versus left. Very helpful. I like to feel the good side first, and then I like to feel the uninvolved side. That's my opinion. I do that almost every patient. Feel the good side, feel the uninvolved side, and compare the difference. Okay, because if the involved side is really loose, if the good side is really loose and the involved side is tight, then I know that tightness is the problem. If the good side or the non-involved side is tight and the involved side is very loose, then I know that the scapular stability isn't there. If it's bilateral symmetrical injury, then you have to use your best, just your clinical reasoning skills, whether you think it's normal to have a downwardly leaning scapula or it's abnormal. Same thing as before, just this, we're going to go in this direction. Move with me now. Good. So the range feels great here, but if I wanted to give her resistance, I can give her resistance this way or this way, depending on scapular position pattern. Okay? Sometimes they do scapula first and then upper limb, and sometimes they do the reverse, and that's just based on, fatigue issue. Maybe you want to give resistance to get that muscles to fire before you do the upper limb. So you got to see how it goes. That's what I would say. For me, I just practice by feel. It goes all how it feels. Does it feel good or not? Okay. So what I want you guys to do is to practice your hand placement, practice the diagonals, scapular diagonals, and then we're just